regimen in people with renal insufficiency. And the only difference, I think, would have been we would have used Cytoxan in combination with something else. And that something else out here typically would have been bortezomib. I'm not sure that you have bortezomib available there. Do you? Velcade. Do you have Velcade? No. It's interesting that you have lenalidomide and not Velcade, but that's good. So Velcade is another very safe drug for patients who have renal insufficiency. And generally, I think what with myeloma, what we've learned is when we combine drugs, you get better responses. And in a person like him with very high numbers and already impacted renal function, the key is to try and get that protein number down. The other thing I would mention, before I do that, you did do a bone marrow to confirm a diagnosis of myeloma. Do you all send off marrows for molecular testing, cytogenetics, and FISH, or not really?
Not really.
Okay. All right. I don't think that's important really. It is important from a prognostic standpoint. I don't think it necessarily changes what you would do for a person in terms of treatment, because I don't think we're at a point where we're necessarily adopting a risk-adapted treatment strategy for myeloma. In my mind, every person with myeloma should kind of get the best possible upfront treatment to try and get them under adequate control. But just so you all know, if you did do cytogenetics and FISH, now he had pretty high tumor burden to begin with. It is very likely that you will see cytogenetic abnormalities in him. Typically in our patient population, we don't see cytogenetic abnormalities in more than 80% of people. It's only about 20%, and if you do see a cytogenetic abnormality, it's generally considered high risk. In the other category, if you look at FISH abnormalities, the one which kind of always stands out is deletion 17 or the p53 mutation, and other things like the 414 translocation or the 1416 translocation are considered poor prognostic factors. So for the future, or when you have resources available on a starting bone marrow, it's important to send off for FISH in addition to cytogenetics, because majority of patients will have cytogenetics be negative. The other thing about Cytoxan, you used 1,000 milligrams of Cytoxan. I think it was once every 3 weeks, which is an okay dose, but it's on the lower side. And if we look at some of the regimens where we use Cytoxan, bortezomib, dexamethasone as combination strategies, what we're typically using is this was based on the Evolution trial. It's a phase 2 trial, and what we're doing is using bortezomib once a week, 3 weeks in a row, so day 1, day 8, day 15, and it's about 500 mg per meter square. So it would be close to about 3 grams of Cytoxan over a 3-week period. So there was room to go up on Cytoxan. Oftentimes, if you have patients like this with renal failure, giving them even at one time going up to 2 grams of Cytoxan, actually tumor reduces them quite well. But once that happens, you are stuck with neutropenia and thrombocytopenia, and you are going to need to support these patients quite a bit. But Cytoxan tends to be very safe. The other question I had was, I know you gave him Cytoxan once every 3 weeks. Did you give him any steroids at all? Dexamethasone?
Yeah, he was given dexamethasone.
Yeah.
With
So you got the typical 40 of dexamethasone 4 days in a row?
Yes.
Okay. So Dex, both for the cord compression as well as for his myeloma, and in a resource limited setting, I would actually go back to, if he's able to tolerate kind of high dose pulse dexamethasone, it's very useful. And in fact, it's one of those drugs which as a single agent has 40% response rates. So Cytoxan with Dex 4 days on, 4 days off, which we typically don't use anymore because of the toxicities. And we have other drugs that we can reach out to. But otherwise, I think using steroids is a good option. The other way to do steroids sometimes is using them IV. Solumedrol or methylprednisone can be given, and you can give 100 IV TID, and it's really good at tumor reducing these folks. Unfortunately, I think he seemed to have progressed through the cytoxan treatment, and he went on to keep getting worsening of his kidney function, which happens with myeloma if you don't control the myeloma. So